as long as we're at this number one on the list, arteriosclerosis being the number one killer, what are the major ways to prevent it?
Yeah, so there's three big ones that stand out, top and center. And then there's kind of a fourth one that I think is the foundational piece. So the three big ones we've talked about: one, blood pressure. So if your blood pressure is 120/80 or better, that's important. The second is not smoking. So it turns out that smoking and blood pressure are both devastating for arteries, but for different reasons, right? So smoking is devastating from a chemical perspective. So it's completely irritating to the endothelium. So the endothelium, as you know, is the single cell lining that is the innermost part of the arterial wall. So this is a pretty special organ. Again, it's a bit naive, but understandable that people just think of arteries as tubes. They're much more complicated than that. They have many layers to them, but this particular layer is unusually important. It has an outsized importance because it is the one that's in contact with the luminal side, right, where the blood is flowing in the tube. And anything that injures that has significant consequences. So smoking is irritating to that in a chemical way, and blood pressure is irritating to that in a mechanical way. So those two things, basically, you just want to, that's the low-hanging fruit in my world, right? You just don't want to have those things causing irritation to the endothelium because that renders you now susceptible to the third factor, which is ApoB-bearing lipoproteins.
I want to talk about ApoB in depth, but as long as don't smoke is the second recommendation on the list, can we better define smoking and what's being smoked? So assume nicotine for,
right.
What about cannabis? And what about vaping of nicotine and cannabis? Because vaping has become so much more common.
Yeah. It's a great question, and it's sadly something we don't have a great answer for. So I can certainly tell you that there's no reason to believe that smoking cannabis is somehow better than smoking cigarettes. But the dose seems to be significantly lower. In other words, let's consider a person who smokes a pack a day for 20 years. We call that a 20-pack-year smoker. Someone who smokes 2 packs a day for 15 years is a 30-pack-year smoker. That's a person who's dramatically increased their risk of many cancers, including lung cancer, and also their risk of cardiovascular and cerebrovascular disease. Again, I'm not a THC guy, so I can't necessarily speak for the habits of people that are smoking marijuana. I can't imagine they're smoking that much.
Probably not.
Yeah. So while on a joint to cigarette basis, they're probably equivalent in terms of harm. I don't know. Let's say a person smokes a joint a day. That would be like smoking a cigarette a day. That's a 20th of a pack. Again, I don't want to say that there's no downside to that, but it's probably significantly less. So I don't think the risk fully tracks. I think the same is probably true for vaping. And I want to be clear, I don't think vaping's a good idea. The last time I looked at the data on this, it was surprisingly sparse. But to me, the only advantage I could see to vaping was if it was the only way a person would stop smoking. So there was, I sort of looked at it as it was definitely the lesser of two evils, but by far the better scenario was not to do any of these things. If nicotine is what you're after, there are better ways to get nicotine, for example, through lozenges and gum and things like that. So that you shouldn't be turning to those things to do it. But if it was like, if gum is here and cigarettes are here, vaping was probably here. But boy, I don't know.
For those listening, Peter spaced his hands far apart for gum and smoking and put vaping about a third of the way from gum toward smoking. In other words, vaping isn't good for you, but it's not as bad as smoking.
That would be my, I mean, you've probably looked into this as well. What
yeah, we did an episode on nicotine. I did an episode on cannabis, and the discussion around cannabis gets a little contentious for reasons that aren't important. It's kind of funny. People, the moment someone starts to confront cannabis as a potential health harm, people say it's not nearly as bad as alcohol, which is a crazy argument. right? Getting hit by a bus isn't nearly as bad as getting hit by a motorcycle in most cases, but sometimes, so that's just kind of silly. And clearly cannabis has medical applications.
Yeah.
Clearly. And then it becomes an issue of the ratio of THC to CBD. Pure CBD forms actually being quite effective for the treatment of certain forms of epilepsy, so-called Charlotte's Web. That's actually what it's called. Very high THC containing cannabis clearly predisposes, especially young males, to later onset psychosis. Those data are starting to become clear enough to me anyway, that people ought to be aware of them at least and maybe make decisions on the basis of those. When it comes to the smoking versus vaping, it's just very, very apparent that the chemical constituents of the vape and what people are inhaling are terrible for people and are loaded with carcinogens and a bunch of other stuff, many of which cross the blood-brain barrier. So that's what worries me the most. Obviously I'm not a clinician, but anytime I hear about small molecules, these small inorganic molecules getting across the blood-brain barrier and then being maintained in neurons for many, many years, I worry because the experiment is ongoing mostly in young people. So anyway, without going too far down that track, I think if people can avoid smoking and vaping, they should. And as you mentioned, there are other delivery devices for nicotine and cannabis, tinctures and patches and gums and things that, edibles that if people choose to use those substances, they can offset.
I think sometimes people would benefit to imagine what the surface area of the lung is, right? If you took the alveolar air sacs of the lungs and spread them out, you would easily cover a tennis court.
Remarkable.
So just think about anytime you inhale something, you are exposing, your body is so adept at absorbing it. I mean, we have this unbelievable system for gas exchange that was designed for gas exchange. And anytime you're putting something else in that wake, you're doing a really good job of getting it into your body. So be mindful of what that is. And that applies to pollution too. I mean, the PM 2.5 data is pretty good. I think once so particulates that are less than 2.5 microns are getting straight into the body, which is a great argument for avoiding air pollution, right? I mean, I always find it funny, not to get off on this tangent, but to me, the most compelling arguments around cleaner energy have nothing to do with greenhouse gases. They have to do with air pollution. I promise you more people are dying from the particulate matters in air that result from burning coal than are ever going to die from the CO2 emissions that result from that. And I would argue that's going to be 2 orders of magnitude. It's not even in the same zip code.
That makes sense. During the fires, which seemed to follow me, because when I was in Northern California, there were a bunch of fires and we were constantly looking. You'd wake up in the morning, everything was covered with ash. My dog was having trouble breathing. I was having trouble breathing. Everyone was suffering. But there are websites that one can go. You can just look at air pollution. And we tend to only do this during fires. And then when I'm in Southern California, there tend to be fires here. So, it's correlation, not causation. But for sure, I didn't set those fires, folks. But it's clear that it disrupts your breathing for a very long period of time. But it's the long tail of that we're really talking about here, the very small particulate that we know firefighters, for instance, and certain industrial workers can end up with that stuff embedded in their brain tissue for extremely long periods. It's just not good. You make a really interesting point about the call for cleaner energy. Can we run that one up to Washington or settle some of the debates about climate change just by getting straight to the health need? I feel like just bypass all the garbage that's being spewed back and forth and basically get to the issue at hand, right?
Yeah, just make it better for people to not die from the direct consequence.
So, trying to avoid such a difficult word to say, especially for a neuroscientist, arteriosclerosis. Did I get it right?
Well, it's athero, which is easier because,
Atherosclerosis. Oh, there. Okay, I've been making life more complicated for myself. Typical of me. Okay. So blood pressure, keeping it 120 over 80 or better. Don't smoke. Let's just throw in don't vape.
Sure.
I'm going to just plant my flag on it. Just don't vape. There are other ways to get those things in your system if you really want to get nicotine or cannabis into your system. ApoB. What's the story with ApoB?
Okay, so to explain this, you have to tolerate a little bit of chemistry. So everybody's heard of cholesterol, and I I certainly devote quite a bit of time in the book to explaining this because it is so important. And it's definitely one of those areas where I initially received a lot of pushback from the editor, and there was a thought that, hey, this is a bit more technical than it needs to be. But I think that sometimes you do need to resort to longer dissertations to dispel mythology. So cholesterol is a lipid. It is a molecule that the body synthesizes. It is a molecule that is essential for life. So if you cannot synthesize cholesterol, you can't live. You'll die in utero. So there are rare genetic conditions that prevent the successful synthesis of cholesterol. Embryos that have those mutations do not survive. Okay, so why do we need this stuff? So we need this stuff primarily for two reasons. First, it makes up a very important structural component of cell membranes. So as you know, a cell is a sphere. We look at them and think they're circles, but they're spheres, and they're fluid, right? They aren't just like little perfect, big bowling balls or, balloons. They actually morph and shape and move in these paths, and this is what allows cells to be next to each other and all sorts of things. They also have channels across all of them, and those channels are held in place by, among other things, cholesterol and phospholipids. The second thing that makes cholesterol so important, it is the precursor to some of the most important hormones in our body. So our sex hormones, testosterone, estrogen, progesterone, in addition to glucocorticoids. If you look at them, it's really funny. People, if you Google, like, give me the structure of these things, you're kind of like, wow, they're all basically the same. They all look really similar, and they're all pretty much just templates of cholesterol. So understandably, when it's something that's that important, the body would leave nothing to chance. We make all of our own cholesterol. The cholesterol that you eat in food, largely irrelevant. It's esterified cholesterol, so it means it has an ester side chain. It's too bulky to absorb in the gut, so most cholesterol that you eat in food just goes out your GI tract. Okay, so we have this super important molecule that every cell in the body makes, but there's a bit of a problem. There's actually two problems. The first problem is not every cell can make as much as it needs all the time. So you have this demand problem. So for example, if you're sick, you're going to need to make far more glucocorticoids. Your body's response is going to be to ramp up cortisol production, to mobilize fuel and do a whole bunch of other things. And certain cells, like the adrenal glands, are going to be called on to rise to a higher level of performance. And they're not going to be able to make enough cortisol. So they're going to have to borrow or take cholesterol from other cells in the body. In fact, one of the things we used to notice in the ICU, I never knew why it was happening. I now know, is the few times I would accidentally order the wrong set of labs on a patient in the ICU and also order like a lipid test or something, you would always notice their cholesterol levels were dropping, serum cholesterol levels. And I now realize why, because they were basically just funneling cholesterol to the adrenals to make more of the cortisol that they needed to combat whatever they were in the ICU for, which is usually the most severe form of stress the body is under. So you have to be able to transport this stuff. And then the second problem is, as you know, cholesterol, being a lipid, is not water soluble. So the most dominant highway in the body is the circulatory system. We can use the lymphatic system and things like that, but for the most part, we use our circulatory system as the highway to move stuff around. And the highway is made up of water. Plasma, which is the liquid component of your blood, is water. And therefore, things that are water soluble move easily. So glucose, sodium, electrolytes, all of those things are dissolvable in water, and therefore they don't need a carrier. You just dissolve them in the water and they can go. So that's why your liver can make glucose that your brain can easily get, and there doesn't need to be a carrier or an intermediary or anything like that. But unfortunately, with cholesterol being a lipid, we can't do that. Just as water and oil don't mix, cholesterol and plasma don't mix. So the body had to come up with a trick. And the trick was designing a vehicle that was water soluble on the outside and fat soluble on the inside, that you could bury the cholesterol inside along with triglycerides. And on the outside, it was covered in protein, which is water soluble. And that's the thing that moves around. And that thing is called a lipoprotein. And as its name suggests, it's part lipid, part protein. Lipid on the inside, protein on the outside. And those lipoproteins come largely in two different families. So one family comes from a lineage called ApoB. So the ApoB family, which is short for apolipoprotein B100, is a family that is derived from the liver, and each of those lipoproteins has one and only one apolipoprotein B100 on it. We shorten it and just call it ApoB because we don't really worry about apolipoprotein B48, which is attached to chylomicrons that are responsible for fat absorption in the gut. They're very short-lived. They don't really factor into atherosclerosis. So we're going to just, for the purists out there, there's an ApoB48. We're not going to talk about it. So when I say ApoB, what I'm talking about is a protein that wraps around a subset of these lipoproteins. There's another family of lipoproteins called ApoA, or apolipoprotein A. This is a much more complicated family, and I'm not going to talk about it here because we would take an hour to just explain how the apolipoprotein A family works. But I'll give the punchline is there are many apolipoprotein A's. There's variable numbers of ApoAs on those proteins, and they are all part of a family called high-density lipoproteins. Back to the ApoB guys, they are of the low-density lipoprotein lineage. So you've heard the term LDL and HDL. What is it referring to? It's basically referring to the relative concentrations of protein and lipids in the lipoproteins. And not surprisingly, based on their names, the HDLs are higher density, more protein, less lipid. The LDLs, low-density lipoproteins, and VLDLs, very low-density lipoproteins, and IDLs, intermediate-density lipoproteins, are all lower density, which means more lipid to protein. There are different sizes. There's a whole bunch of other things going on. The most important fact in all of this is that the ApoBs are atherogenic. So what we're about to talk about next is perpetuated by lipoproteins that have an ApoB on them. So everything in the story right now is just about how do you get cholesterol around the body.
Mm-hmm. And these proteins that have lipid in the middle. So let's just take ApoB, for example. Many, many billions of them floating around in our body, even in the healthiest of people.
Yep.
And they're being shuttled to tissues that need them, like the adrenals, muscle, heart, etc. What sets the demand for these things? So for instance, could somebody have relatively high LDL, maybe even higher than sort of high end of chart or even above high end ApoB, but there's some sort of demand, metabolic demand, or they're weight training a lot, or they're running marathons, and so they need a lot of LDL. The reason I ask this is because it's so easy for the uninformed person, which I include myself in that group, to just hear, oh, LDL bad, cholesterol bad, ApoB bad, when in fact, you very graciously spelled out the fact that these things actually perform a functional role in the healthy body. So before we get into why they are or can be bad, why would you want a low density lipoprotein? What is that doing for somebody? And is there any circumstance where the way people are exercising or thinking or not sleeping or sleeping too much, it's that a higher level actually reflects a healthy metabolic need?
We don't have any evidence of that to date. All of the functions that I described can be done by the HDL. So the high density lipoproteins, the ApoAs, can do all of it.
So ApoB and low density lipoproteins are just they're just the necessary
we don't actually
waste. I mean,
we don't understand why we have them, Andrew. This is the part that's really interesting to me. Most species do not even have ApoB. And as a result of that, most species are chemically incapable of atherosclerosis.
So if someone could zero out their ApoB and their LDL, we assume they would function just fine.
we know they would because we have certain people who walk around with genetic mutations that render them that way.
Wow.
Furthermore, we also know that there's a bit of a myth out there that the cholesterol you measure in your blood is essential for brain health, for example. That's an understandable thing, right? You can speak to this very eloquently, the role of cholesterol in the brain.
Yeah, I wrote down that when I was a postdoc at Stanford. So I always point out I was born at Stanford, trained at Stanford, works I'll probably die at Stanford, hopefully a long time from now. You'll tell me how long from now.
Well, we're going to do the Charlie Munger thing and make sure that you never go back to Stanford so that like you can't die there.
There, exactly. We cured already. When I was a postdoc, I worked with a guy named Ben Barris, who I know you know probably as a different person then for reasons that people can look up Ben's name. Anyway, incredible scientist. But there was someone in his lab that discovered that cholesterol is a critical component of the synaptogenesis process, the formation of connections between neurons in the developing brain. And then that went on to lead to the discovery of things like thrombospondins being important for synaptogenesis, et cetera. But cholesterol sits central in the brain development mechanisms. Like you want cholesterol around for brain development. In fact, I think very low-fat diets and very low cholesterol diets during early development can really impair brain development, as I understand.
Yeah, it's not entirely clear why, but here's what we know. When you're born, your serum cholesterol levels are very low. So infants and children have very low levels of cholesterol. They would have, and I should explain one thing that's important.
They're not myelinated yet, right? I mean, they're sorry to interrupt, but myelin, of course, the sheathing around neuronal axons, which accelerates the propagation of nerve signals and which is deficient in things like multiple sclerosis, is essentially fat made up of phospholipid. And requires cholesterol for synthesis, but young children are not very well myelinated. I mean, the spinal cord is
right.
Spinal tracts are myelinated.
So this is what's interesting, right? We would all agree that cholesterol is more important to infants and children than to anybody else, right? It would be the most important substrate for CNS development, and yet infants and children have virtually unmeasurable levels of cholesterol. It really starts to take off in your teenage years, right? So serum cholesterol levels rise basically monotonically throughout life. Women get a big bump at menopause, so it really goes up for them. But what's interesting is how do we reconcile the fact that infants and children have really low levels of serum cholesterol, yet clearly undergo CNS maturation without any problems? And it basically comes down to the following. What you measure in the serum is but a fraction of the total body pool of cholesterol. So we get a little bit of the light under the street lamp under the drunk under the street lamp problem, which is just because we're looking there, we tend to think that that's what we're seeing. But if you took the entire circulatory pool of cholesterol, it's about 10% of your total body cholesterol. It's a tiny fraction of it. So it's what we measure because that's all we have access to, but it really represents virtually none of it. I do want to say something because you mentioned LDL. I want to tie this back to the reader, right? Or the listener rather. ApoB refers to the lipoprotein, the singular lipoprotein wrapped around an LDL particle. So if you happen to be lucky enough that your doctor measures an ApoB level, it's a blood test. It says ApoB X number of milligrams per deciliter. That's measuring the concentration of that protein. It is a direct measurement of the concentration of LDL and VLDL particles. When you have a blood test that says LDL, it usually doesn't say LDL. It usually says LDL-C or LDL cholesterol because LDL is not a laboratory measurement. LDL cholesterol is a laboratory measurement, and it's just taking the total number of LDL particles, breaking them apart, and measuring how much cholesterol is in them. So LDL-C measures the total concentration of cholesterol in the LDLs. ApoB measures the number of them. And they're different, but one of them is far superior at predicting risk, and it's ApoB. The number of particles is much more predictive of risk than the amount of cholesterol contained within them.
Fascinating. First time I've understood HDL, LDL, and these lipoproteins in a way that makes sense. So thank you. I'm sure others feel the same way. What ApoB level is your red flag cutoff?